Steve, it is 9 o'clock and your waiting room is cleared. I saw yourself, Brandon, and I believe Kristen log in. If I missed any other TAC members, can you please let me know?
Yeah, that's what I had.
Okay. Sometimes when you guys come in a big group, I don't catch you all.
Right, that's understandable. All right, well, absent the quorum, we cannot move forward with the minutes, correct?
Correct.
All right. Well,
And I'll keep an eye out to see if you have other members join.
okay, sounds good. Let's go on to the DMS update.
This is Leslie. I'm sorry. Angela's going to be giving the update today. I apologize. I had trouble getting into the meeting, so I apologize.
Okay, thank you.
Good morning. Hope everyone has had a good start to the new year. It's quickly flying by into January. So wanted to provide a few updates since the last meeting. Again, through the holidays, I know that there was a lot going on for everyone. Again, Angela Sparrow, I'm one of the behavioral health supervisors within the Department for Medicaid Services. Wanted to provide some updates in the status of the reentry application and where we left off last time. So again, thank you for everyone who was able to join and listen to the public forums to hear the information regarding the application draft. The public comment period did run through the 9th or 10th of December, I believe. Following that, again, we did receive, I think, again, 13 submissions, official submissions regarding comments, again, from different agencies and individuals. Again, a lot of support received. We did receive some overall comments. They were, again, generally regarding the settings that were being requested and the services that were being requested. So just want to let everybody know the responses to those comments that we did receive. And again, a summary of those are posted to the Medicaid website. And so I'll go ahead and drop that in the link when we get finished here. So everyone can review that. So we certainly appreciate the information and participation in reviewing the application. I think, again, we tried to be very transparent through the process that we do anticipate as we go through the implementation planning process that we will consider, and then again, once the hopefully to seek a more timely approval from CMS, that we will look at expanding and growing as we work together through that process. So again, we'll send that information so that you all can see that. For everyone who did submit comments, hopefully, again, you did receive an email back acknowledging that and where you could find response to that as well. So with all of that being said, again, we did make some minor changes to the application. Again, nothing significant in the way of the services and settings in the benefit package, but did include some of those recommendations. The application was submitted to CMS on December 30th. We should have that posted to the website by the end of the week. I needed to make some updates with some of the links that were included in that. And so that should be posted and can be viewed in the same location as the comments. So you all should, again, be able to view the official submission to CMS. They do have 14 days to review that for completeness. And so, again, that's by no means approval, just saying that, again, the state did include everything in the application that was needed for them to be able to review that. So we hopefully anticipate receiving that letter next week, and then the next steps would be for them to move forward with a federal 30-day public comment period before they can begin reviewing that. And so we, again, anticipate working with CMS through the first of the year. And then again, throughout this year, we do have several pending 1115 initiatives. And so we really want to work with them as to how we can streamline those requests And again, hopefully seek as quickly as we can approval for all of those. They are very complex in terms of the implementation plans that are required, the monitoring, evaluation protocols. And so again, each of those initiatives require those separate things. And so we want to work with them to see how we can move those things forward and hopefully align all of those initiatives as well. So I'll pause there to see if anybody has any questions, but again, is in terms of the SUT waiver, we anticipate, receiving beyond the temporary 1-year extension. We felt in conversations with CMS that really that temporary extension was to align many of these initiatives that they knew were coming forward with our SMI amendment, with the reentry amendment, and so forth.
Angela, I asked this question a lot. I never remember the answer. I apologize. What's the time frame? I know 14 days, they just confirmed they've received it. What happens after that?
So again, their 30-day federal comment period before they officially start reviewing the application. And so they initially, and again, it can vary and differ. Typically within 30, 45 days or so after they officially begin reviewing it, we'll get an initial round of questions. And then so we'll take a look at those, respond to that. And then they'll take some time to review those, and then that kind of starts the negotiation period. One thing that we want to have a conversation with CMS, knowing their timeline, and again, the amount of requests that they have from states reviewing as well, is what we can do in terms of our standard terms and conditions that's typically issued with the approvals, is how much of that, again, the state can draft and help them through the process as well. And so again, that's just as we start to meet with them again into the new year, those are the conversations we'll have, and what we can do to help with all the initiatives that we've requested to move those forward. And so again, do have to remind everyone, even once we receive an approval, the state then has to submit the implementation plan to CMS. And then they have to review that, approve that before we can actually implement. So even once we receive an approval, there is still that period that we have to work through before we can actually implement and go forward. So we do hope to kick off the ACRES, the advisory work group. We were hoping to get those invites out before the first of the year, but those should be coming out again soon, so that we can get that group together. The plan is to be able to work through some of that implementation planning prior to the approval, so that we really have a head start on that implementation plan and less time again to turn that around to CMS. And again, try to move it forward as quickly as possible.
Okay. July 1, September 1, is that realistic?
Yes. So again, our extension period for the overall 1115 is runs through September 30th of this year. We hope again to be able to seek approvals prior to that and not wait that
Okay.
long. So that's the goal. That's what we'll push for into the new year.
Any questions?
Steve, this is Erin. For the record, Angela and Kevin both logged in, but we still don't have a quorum.
Right, we're at 5. I'm counting.
And, oh, sorry. Not to jump ahead, but I can also provide as part of the DMS updates, the number of, I think we typically provide the number of incarcerated individuals. If you want me to go ahead and give that we have currently.
Yes.
As of this week, there are 13,832 individuals that have suspended coverage due to incarceration. And I think the total enrollment is at 1.5 million or so.
A lot of people.
Yeah.
All right, thank you.
You're welcome.
Appreciate it. I had an opportunity to talk to some UK folks, and it really relates to hepatitis C. And it's the 90 days versus 60-day pre-release. I know CMS is 60 days. I'm sure the comments were maybe 90, and I'm not sure we can do much of that CMS's perspective. But I have two folks who are able to join us this morning to talk about really the 1115 waiver and maybe some federal comments we may want to submit, or someone may want to submit. And that is, they are, where's my list? I'm messing myself up here. Oh, Mary Beth Wright and Deborah Duckworth, and they're with, really want to talk Hep C and what can be done and their experience within facilities. All right, Ms. Wright. Yeah.
Thank you very much for inviting Mary Beth and I today on behalf of UK Healthcare. I'm Debbie Duckworth, so I am the Senior Director over UK's Specialty Pharmacy and Pharmacy Infusion Services team. We started our hepatitis C program back in 2013, 2014. And right there at the beginning of that, I was able to coerce Mary Beth Wright into joining our team. And she has been working in the infectious disease and hepatitis C space ever since. So just to give you a little bit of background, despite really strong collaboration within our clinic, our pharmacists were embedded in our clinics and had really strong relationships with our providers and our clinic staff. We were only able at the height of our program prior to the pandemic to put 10% of our identified patients linked to care and on Hep C treatment. And that was taking on average 500 days to do so. That's pretty abysmal when you think about it.
The 500 days was for what? What was being measured?
Average time to get a patient on therapy. Now we have a large cohort of patients, but there's many struggles within the patient population, as most of you probably realize. That Hep C is a syndemic with substance use disorder and many other things. Daniel Moore, Dr. Daniel Moore, Mary Beth, and myself have been on the Kentucky hepatitis TAC, and trying to work with that group. It's a very challenging project for the state of Kentucky, and I think everyone realizes that we are the hotbed of hepatitis C in the United States. So the three of us got together, and we, feel like we are beating our heads against the wall in terms of moving the needle on hepatitis C in Kentucky. Of course, we're trying to eliminate by 2030. And so, our premise is, well, you're going to get the same outcomes if you keep doing things the same way. So we invited, process engineering to meet with our teams. We did almost a full day of project work with that engineer, trying to eliminate waste and see how we could make a dent in this 500 days and treat more than 10% of our identified patients. Now, Mary Beth's going to show some slides that will help you understand what our results have been, which with the general population has been very successful with the outcome of that initial project. But we also know that we cannot eliminate hepatitis C in this state without a strong partnership and very innovative approaches for our incarcerated and paroled populations. So we've been working with Commissioner Cookie Cruz, who those of you who know her know she's very passionate, and we are very blessed to get to work with her and her team to try to make a difference for this population. So what we wanted to share today has been that journey, and so why we, commented on the waiver initially from the perspective of UK healthcare and these patients. So I'm going to turn it over to Mary Beth right now and let her share what we've been doing.
So I'm Mary Beth Wright. I'm the pharmacy manager for our infectious disease team. I'm very passionate about Hep C. You're going to see that very quickly. As Debbie said, the 511 days was just not acceptable and less than 10% treatment. What we have found with our numbers, and I'll just give you a very brief overview, is that we now are treating close to 62% of the patients, meeting them where they are in the system, not creating additional visits, streamlining those visits. Of those patients that have, and it's taking an average, a median of 17 days with an average of 26 days to get them on treatment. We have substantially decreased. We've increased treatment uptake by over 500%, and 86.5% of those patients have either completed therapy. We just now are starting to draw SVRs. We've been doing this over 6 months now, this week. We're getting outcomes, and 86.5 have been compliant and completed all 3 fills of their medication. That is unheard of in this population, so it is working. What I am begging is that we consider something similar, that we decrease and make this as accessible as we can to all prisoners. And that is what I hope the waiver will do, will allow you to get them drug in hand before they leave that prison, and we can get those fills completed. If that could occur, I think that you will see we will hit a very high source. Here are the numbers that I want to share with you. Our program, Cookie was able to obtain a screening grant to begin HIV and Hep C screening in our prisons, in our county jails, okay? We screen the state prisons, but state prisoners housed in the county jails have not had that opportunity. They're getting that upon discharge when they're within 30 days, and we've now moved that to 60 days. So what's happening is those patients, when they're within 60 days of discharge, they get a screening test for Hep C and HIV. What we are finding, we are doing this we started in 5 county jails. We've now expanded to 6. We're going in our 7th this month. As a matter of fact, the first meeting was yesterday, and we intend to add 1 county jail a month. Here are the numbers for positivity rate. We have almost 60% positivity rate in those 6 county jails of antibody positive, okay? Just a little history here. An antibody positive means that you've been exposed to Hep C. You may or may not have a chronic disease. Of that 60%, 67% have an RNA positive, which means they have a chronic infection. So you can see of those patients that have been discharged just out of these 6 county jails, we have close to a 70%. At one time, it was running as high as 76 to 78% positivity. We have an issue, and we can't begin to address the epidemic of Hep C in the state of Kentucky if we don't somehow include the entire prison system. We have that's a potential not only for your workers, but for your other prisoners housed in that area. Transmission, and it scares me. I'll be honest with you. And I've been doing this since 2015, as Debbie said, and I have a real passion. I know the costs. The costs are high. And I know that we would have to figure out an innovative way to try to find funding for that. I'm not unrealistic. Realism here is that it is a very high dollar. The other issue here is it may be high dollar, but the cost of inaction here at UK, when we decided to look at our numbers, okay, and we've had approximately, if we were to cure 34,000 patients, okay, and that's realistic. We have 5,000 that have been identified that have never been treated already currently. We could save the state in 5 years downstream cost of advancing liver disease $4.2 to $6.5 billion if we were to treat 34,000 people over 5 years. The cost of inaction is much greater than the cost of action. You have a captive audience with them in the prison system. If we could get 60 days, we could probably get it treated. The screening period might be longer, but if we could get 90 days, you could get all 3 months of treatment in before they're discharged. And all you've got to do then is check one lab level 12 weeks after they complete therapy to know that they have a positive outcome. The potential here is fabulous, and you have a captive audience. We could do something about this epidemic and slow down the syndemic of all the substance abuse and things like that. If we could get both substance abuse and Hep C combined to be addressed in this waiver.
What happens if they get the treatment for 60 days, released, and then they don't get the rest of the treatment? What's the outcome?
Well, I'm supposed to tell you there's a possibility that they might not be cured. I have seen patients that have, and this is not the norm, okay? But I have seen patients that have taken as little as 7 days of treatment and it cured their Hep C. I've seen them take the full 3 months and not be cured. So there's no way to predict that. The literature shows that if you are 50% compliant, at least 50% compliant, that you should cure that they have studies showing that you could cure the disease. So if we were to get 2 of the 3 fills, if we could arrange this right so that the screening's done at 90 days and you have that fill right at the 60-day mark where that waiver were to kick in, you could get 2 fills. You can proactively, we do proactive refill management, so you can fill meds at 21 days. They get a 28-day supply. You could fill them at 21 days. You could fill them 21 days later, and they would have all of their drug in hand when they were discharged from the facility. You can do this. You have a much tighter window of time to do that in, and you would have to be very good at your time window and your dates, but this is possible. Now, I will say, if they go back into community and they have not, and they reuse, they can be reinfected. And then it's a much more complicated treatment. However, you make your jails safer, you make your employees safer by curing this disease and getting them on treatment. Of course, it's at the end of their stay. Realistically, it's at the end of their stay.
Wow.
The numbers to me are very concerning, as I think they are to you. And some of you on this committee have heard me say those numbers before. They're very concerning.
Is there any data on correction staff who have become infected? I mean, do you know the numbers of that?
I don't, and I don't think there's any way to know short of testing them pre and during if any symptoms come up. And that's the problem with Hep C. It's a silent disease. If you're not having regular labs, you're probably not going to see those liver enzymes creep up. You're not going to know until you have a more advanced disease. It's a silent disease.
Debbie and Mary Beth, I think again, we absolutely appreciate the information and you sharing, and it's something that we do want to partner. It is a great concern, and you're correct. The numbers are very alarming. I think again, we do have an opportunity, and I think we certainly have an opportunity to begin addressing it with the initial request. As well. And so again, I think the initial thought, because there were other legislation initiatives that did require the state to, submit the request more timely. And so when we do request that, we do have to have the budget portion of that and all of those services that we request included. This waiver was very different in terms of the reinvestment component as well. And so those things were certainly a factor. Again, I think the intent is to, through the implementation planning process, begin to think and consider the other facilities and settings and services, although they weren't initially included in the initial request. But to consider that as we begin to build out, so that when we have an opportunity to request an amendment to change the demonstration and expand the demonstration, we really have that already thought out, and that we have those procedures in place and our systems set up to do that. And so I think that, again, the intent is to consider many of those other things that have been suggested as we move along. It is difficult with the jails, being that there are so many in the state. Many of those have different policies and procedures. Under the demonstration, again, any of the benefit package has to be available in every facility. And so that is very challenging with our jails. And so that, again, was one of the reasons to begin to request with our state prisons and our youth detention centers. But again, the intent is, even though that they were not included in the initial submission, to consider them as we planned, so that we can think of corresponding and parallel what an amendment would look like and how we can bring them on board more timely. So that was a piece of that. So in terms of hepatitis C, I think that we have some initial thoughts on how we can include and start through the initial ask. And so that's something that we want to work with Department for Corrections, as you mentioned, through the health risk assessment that they initially receive when they enter the facility. But again, through the reentry process and the post-release process, through the case management services that the individual will receive, and through some of those requirements, there's an opportunity, again, that through the case management assessment, where we really need to identify their physical, behavioral health, and social determinants needs, that screening, again, is a part of that case management process, so that, again, we kind of build that into that service, so that we, again, are picking that up and screening and capturing that then. And as you mentioned, if they do screen, or if there is a positive, that through the request to cover the medications at time of discharge, and as you mentioned, they're in hand, that again, the medication then is included in that part of the benefit package. So we feel like that there is an opportunity to start through the initial request and start addressing pieces of this. And again, it's not the long-term, I think, solution, or again, but it is a starting point. And it's certainly something that we want to work with you all on through the advisory, again, work group. We do anticipate, once we get that going, we will have subgroups and start bringing in other expertise, again, for those type of planning. And that's something, again, we certainly would want to include your group in, but I think those are the initial thoughts. So I'll pause there to see what you think about that. And again, if you think that that's an option to help us get started in the planning, but like you said, also the budgeting moving forward as well.
Angela, I applaud you. This is a very difficult topic, and we are very well versed. We've been doing this a very long time. We've navigated and changed and altered our processes to finally feel like we are making a difference. And I am thankful that you all are looking at this and making a change in how these patients can have access. We are definitely, Debbie and I both, and our leadership above us are committed to working with you and helping you. I can tell you that our models, we have in the last month have met with the CDC. They're very interested in our models as well. And so I would like for our state to make a difference. And so we are committed to that. And I think that Debbie is as well, to assist us. And I would be willing to help in any way possible.
This is Leslie. I just wanted to say that Angela and I, this was brought to our attention early on. So thank goodness that we were in so many collaborative meetings that, you know, we were learning about this very early. So as you could see, Angela had a set answer that we've been planning on not only Hep C, but other things that we can identify and address early on, so that when the folks leave from incarceration, that they are prepared to leave in a good situation going out into the community. So I just wanted to applaud Angela too. We've addressed many areas in our cabinet and even some outside of our cabinet with this initiative. So thank you so much. And we do want to work with you and figure out the long and short of the 1115 is hard to understand because it's complex, but we do want to figure out a way to how to work with you in the beginning implementation and what we can get into that case management responsibility. As you're aware, we're looking at 60 days prior to release right now, and that was based on CMS's guidance in March, I believe. So we do want to partner with you. We do want to work with you, and we do want to move forward in any way we can integrate on this initiative. So thank you all.
Any questions? I wish we could figure out how to do the screening before the 60 days. So that happens before the 60 days, you can at least start the treatment in 60 days, right? And then we're consistent with the CMS. But if there's not a way to get that screening done, that doesn't happen until, right, 60 days prior, and then probably treatment doesn't start to 30 days prior, right? Is that fair to say?
Right, Stephen. So I think that that's part of the collaboration that we'll need to have with Department for Corrections. And again, as a starting point, right? Is there other funding that may need to support components that Medicaid can't currently cover during a time period as we move and then, you know, amend and expand the demonstration. So, you know, there may be things that we need to discuss in the interim as a starting point. But again, those are all things that we need to work with Department for Corrections and our other agencies to determine again what they're able to support, and you know how we can kind of blend the funds to meet those needs.
Yeah.
Your state facilities,
Yeah.
the state facilities, they're already testing, they're screening. They
Okay.
screen upon admission. So they have that data already. It's the county jails that house state prisoners that don't do that.
Well, it's encouraging, Leslie and Angela, Medicaid's already had this conversation, right? It's on the radar screen already. That's an opportunity to move forward. So I appreciate that. Courtney Ham asked, is there any information on Hep C at DJJ facilities?
Right. Honestly, I can't speak to that. I don't think that is something that we have discussed in the conversations with DJJ from our standpoint, and have that data. I'm not sure that that's come up in our discussions.
Okay. Dr. Wright, anything else? That was good information. It's a scary thing, isn't it?
Yes, sir. Yes, sir. And unfortunately, we are one of the top 3 leads in the nation of Hep C, have led at times. The University of Kentucky has led in treatments being offered in the United States at one time or another, not a statistic that you want to be the lead in. But at least we're treating. At least we're treating, and that's the good news here.
Yeah.
Steve, thank you for inviting us today. We really appreciate that. It's going to take all of us.
Yeah.
And thank you.
Yeah. Thank you all. Good work, Angela. All right. Next. Medicaid billing for clients referred by DOC. I keep this on the agenda. It comes up occasionally when I talk to CMHCs. I have not heard about this recently. So I think we're making some progress there. Let's go to MCO updates. Flip the order this month. WellCare?
Yes, Stewart on WellCare, Chairman Shannon. I guess I whined at the last meeting about WellCare always going last. So thank you for responding to my whining. I guess there's a lesson there for everybody that whining can be effective sometimes. We are super.
I just like the alphabet too, Stuart.
Get a little spicy, mix it up, W is a nice letter, yeah.
Yeah.
Different reasons, not just my whining, I guess. Okay, all right. We're really excited, and we sent an invite to each member of this TAC. I hope they got it. If you didn't, please tell us. We have these different community impact councils, and so we basically we identify community leaders to tackle a given issue, problem in a given community. And so we have created one. We've got such an awesome outreach team that does this, and Laura Chowning is heading this up. Darren Levitz is the key person over all that. But we have one for Frankfurt where we are going to do a reentry simulation. So literally this is simulating what it's like you've just now being discharged from prison. And so the event is Wednesday the 21st. We did send the invite out. It's 11 o'clock to 2:15 at Paul Sawyer Library in Frankfurt. If anybody doesn't have the invite, please let me know. Please say so in the chat. For example, lunch will be provided. So there is such a thing as a free lunch. Sometimes you got to RSVP though, but this is a super cool thing. And I'm going to be there as well. I'm really excited about it. So it's February 21st, Paul Sawyer Library, 11 a.m. to 2:15 p.m. And let me just stop right there. Did anybody, can you confirm? Steve, did you get an invite? Anybody else on the TAC?
I did, Stuart.
Okay, good. All right, very good.
I also got an invite too. I mean, she's doing amazing work. So, I've sent it out to as many partners as possible.
Awesome. Thank you for confirming that. Just some other updates we have is, our care management team. We've been, not me, but our care management team's been meeting with individuals at different correctional facilities in Kentucky, trying to get relationships there, participating in some events with them, all geared toward when members get released from prison in advance so that we can be ready quickly to help coordinate care and everything. But some of the facilities that we've been working with, Blackburn Correctional, which is in Lexington, KCIW Luther Luckett facility, and they've got an event. We're meeting with them next week. Bale County Forestry Camp in a couple weeks. Kentucky Drug Courts. We got a meeting with Drug Court tomorrow. So care management team been very active in doing that. And of course, this will obviously ramp up a lot when this demonstration waiver gets approved. So those are the WellCare updates.
Any questions? Thank you, Stuart. United.
Yeah, good morning. Liz Milburn with United. The only update that I have is that we're going to be attending the Expungement Resource Fair at the Northside Library in Lexington on February 22nd. We had a staffing shortage in 2023, so we have 2 additional case managers that have joined our team, and then I have 1 open rec for another position. So hopefully in the 2024 year, we continue to build on our partnership with the prisons.
Thank you. A lot of us had staffing challenges in 2023. Passport.
Thanks, Steve. It's Mark Zockham. We had no new NGA members in December. We're continually actively working with 3. We did receive 1 new member last month, but they weren't eligible until January. And we've had another member that we received this month so far. In the fourth quarter of 2023, our community engagement team held or participated in 14 events. That includes 6 expungement clinics and resource fairs at 4 of our statewide offices. They also participated in expungement clinics at community partners in Warren County, Wayne County, Bourbon County. One of those was also a vaccination clinic. They also attended 3 pre-release classes or resource fairs at local jails or state correctional facilities. And they participated in 2 reentry simulations at the Goodwills in Fayette and Warren counties. All told, we had over 650 attendees for the events. So far, for the first quarter of 2024, we are participating in 5 pre-release classes at local jails or state facilities, and also 5 expungement clinics, 3 at our offices, and 2 with community partners in Barron and Boyd counties. And I believe that's all I have today.
Right. Thank you. Humana.
Good morning, everyone. This is Kelly Bendorf with Humana. I will start with our updates on our reentry program. We actually had 5 release members in quarter 4 of 2023. That was a slight increase since our previous report at the last TAC. We have had a little bit more difficulties reaching members by phone with these kind of new members that we've gotten. So we're really looking at more creative ways to outreach those members and increase that engagement. We also have continued to have some great collaboration with reentry coordinators, so I appreciate that so much. As for our community outreach, our community folks have been busy. They did some Goodwill Second Chance Days in Rowan County in November and December. They also participated with Goodwill Resource Fairs in Louisville at the Broadway and Preston Highway locations. And we have 2 upcoming expungement clinics that we will be attending. One at Community Action in Lexington in January, and the Madison County Public Library one in February. So really excited about those events. So that's all we have.
Thank you. Appreciate it. Anthem.
Hello, Steve and members of the TAC. Quick update from Anthem. We continue to participate in pre-release classes as well as expungement clinics throughout the Commonwealth, and also continuing to cover the GED supports and costs with that, with the GEDs. We had 6 members referred over to our release case management team in Q4, with a little bit of an uptick in December with 3. As always, we continue to strive to get in contact with these members, and that's kind of some of the largest challenge that we continue to see.
Thank you, David.
Yep.
And Aetna.
Hey everyone, this is Courtney from Aetna. I just wanted to report on a couple of things. One, we have on the Sky side of things, supporting Kentucky's youth, our foster care contract, we're starting to present to probation and parole offices statewide, just to talk about that transition age youth, right? So that 18 to 26, 18 to 24 population, we want to let them know about our Sky program and all the case management support that is received through that program. And then also we are working on an initiative in Clay County Jail, working to bring in a program around fatherhood. And so that's going to be really interesting down the road. Our Start Strong reentry coordinator has been very busy going to all these expungement clinics that have been going around the state. So we're really excited that we've been able to get out and about. And then she's been building a caseload on her own because we just have had just a really small trickle from the state We get one like every couple months. So she's been building a caseload on her own. And really the only barriers that she runs into, which I think probably everyone runs into, is not being able to talk with our members when they're in SUD treatment. So just sort of waiting until they're out of treatment and, you know, they can get those services. But it would be great to be able to build that bridge before they get released from SUD treatment. Really the barrier is, you know, they can either confirm or deny whether that person is there, even though as a healthcare organization, you know, we get claims, we know where they are. So that's one of our barriers. I'm sure other people have run into that. But Lana is on the line and listening to all of this and is always here. She says she's also going to be meeting with drug court in Warren, Butler, and Edmonson County, also to work on, you know, bridging those gaps with members. So we've been trying to stay busy and focus on this population, and looking forward to figuring out this waiver.
Super. We're all forward. We're all excited about the waiver. All right, round robin updates, members, anybody? All right. Any legislative updates people want to share? I'm sitting back waiting on the budget. I want to see the House budget. That's really good. Focuses for us. I keep on here Medicaid eligibility post-release. That comes and goes as problems. We've had some issues. We started working some with AOC, some of their folks who are involved to see if they can help us accelerate that process to get people back on, you know, suspended, get it reactivated. Some of the people I work with have great success. Others, it takes a little bit longer. So,
Steve, this is Leslie. I just want to mention if anybody has some really weird situations that are not able to get corrected and can't get that eligibility moving, just go ahead and, you know, Leanne and I have been working on any of those cases that come in. I will say that they're trickling down though. I'm not getting as many now as I used to.
that's good to hear.
Hey, Steve.
Yeah.
Real quick, I saw a bill, I don't remember it, regarding expungement, that if it's a certain level of crime, that you would be automatically expunged upon release. Wouldn't have to go through the process. I forget the number. I can email that to you, but.
Okay, I'll send that out. Yeah, I saw that. Be a good thing, wouldn't it?
Yeah.
Looks like our next meeting is March 14th. Any other agenda items? I'll ask for future agenda items and someday I'll get one. In the chat, Dr. Wright thanked everybody. I think it was good information to have. I was glad to see both that Medicaid's paying attention to this as well. It's a topic I didn't know much about until about 4 months ago. So I think we need to pay more attention. All right. See y'all in March. Y'all take care.
Thank you. You too.
Yeah. Bye-bye.
Thank you all. Thank you.
Thank you.